We're starting off with this unit, health promotion, and this happens to be the last unit from the component health psychology. And as we see this in other units as well, this unit again is divided into three sections. The first section over here is strategies for promoting health. The second one has to do with health promotion in schools and work sites. And the third one is individual factors in changing health beliefs. So, to begin with, when we speak about health promotion, what exactly is health promotion? Usually, when we're using the word health promotion, we're referring to the efforts that aim towards improving the well being of an individual. Not only improving the well being of an individual, but at the same time, preventing illnesses. Now, there are two key aspects that we're looking at over here. Number one, we're talking about efforts that aim at the efforts that aim at improving the well-being of individuals. Number two, we're talking about how we can prevent illnesses or prevent accidents. Now, how is it that we plan on doing this? We plan on doing this by influencing individuals or maybe influencing certain social groups. And if we're successful in influencing group behavior, we can possibly have a healthier population. We could possibly have a safer society to live in. Now, the question that rises over here is, what role does psychology have to play in terms of health behavior? Health psychology, uh, Health psychology, or if we talk about health promotion under the heading of health psychology, our focus would be towards changing behavior. Our focus would be towards motivating people, and there are other social influences that we could possibly put to use as well. Now, as you see, there are three subsections that we have over here, or three sections that we have over here, the ones that I named a minute ago. The first one being strategies for promoting health. The second one is health promotion in schools. And the third one is individual factors in changing health behavior. If you have a cursory look at this, you'd see that the first section that we'd begin with today has two bullets in it. The first one says fear arousal, and the second one is providing information. Now, when we talk about fear arousal, this is a way this is a way or a mechanism through which you would scare people, and we'd see if scaring people does help, or to when it comes to scaring people to the extent that they end up changing their behavior. Now, another key element, another key factor that we would be discussing over here would be, how much do you think it is enough for us to scare them? If we scare them a lot, there's a possibility that people end up getting desensitized. There's a possibility that they might avoid our health promotional message. Likewise, we'd move on and talk about providing information. To what extent do you think providing information to individuals helps them with uh, helps them stay healthier? So providing information over here, we talk about giving information so people know how to improve their health. Now, if you have a closer look at this first section, you see that there are two example studies that are there as well. For the first bullet, you have an example study that was conducted by Janis and Fishback in the year 1953. And the second bullet, providing information, has another example study that was conducted by Lewin et al. So without any further ado, let's begin with this unit. So as we speak about health promotion, if we have a look at what our book has to say, we'd start off with the strategies for promoting health. Now, understanding what behaviors and decisions are important for our good health is important. However, what is also really important is making people aware of this and encouraging them to carry out these healthy behaviors and decisions. So, the first thing that needs to be understood over here is understanding what sort of behaviors and what sort of decisions are important for our good health is super important. But at the same time, don't you think spreading awareness over what sort of behaviors would improve health, or what sort of decisions would improve health, would be or should be considered important too? So, however, what is also really important is making people aware of this and encouraging them to carry out these healthy behaviors and decisions. Now, there are various strategies that are put to use for promoting health, and they can come in many forms. There are two that we'd be covering initially. Like I'd mentioned, fear arousal, and the second one is providing information. So these were the first two bullets that I'd shown you. The first one was fear arousal, and the second one was providing information. Now, taking this ahead, let's talk about fear arousal here. As we speak about fear arousal, what does the word fear arousal mean? Like I said, scaring people to the extent that they end up scaring people to the extent that they bring in a change in their behavior. Now, about this particular study has been a part of the syllabus, I recall, since long. And this study is a classic study. This has to do with how or the factors that could help individuals improve their dental hygiene. So this study, like I said, was conducted in the year 1953. If we talk about a study that was conducted in 1953, so this is nothing less than 70 plus years ago. Now, taking this further, Janice and Fishback they aimed to investigate the effects of using fear appeals in communication. Now, when we talk about communication, when we talk about communicating with people, to what extent do you think communication can help, and using fear appeals in communication can help people with bringing in a change in their behavior? So Jennison Fishback aimed to investigate the effects of using fear appeals in communications that are presented in an impersonal group situation. So if we have a look at the aim, it wouldn't be wrong if we say that they aim to study how fear based messages influence people in group settings. They also wanted to explore if strong fear appeals could have negative effects by triggering defensive reactions. Now, taking this ahead, this could be seen as the first aim, if I break this into two parts. Number two, the second one. Furthermore, the research aimed to explore the possible adverse effects that might arise from defensive reactions. Or, in other words, is scaring them too much? Or or do you think scaring participants too much would be effective? Or, like I mentioned earlier, if you scare them a lot, there's a possibility that as a defensive reaction, they might avoid that message altogether. So, Jennison Fishback in 1953 aimed to investigate the effects of using fear appeals in communications that are presented in an impersonal group situation. Furthermore, the research aimed to explore the possible adverse effects that might arise from defensive reactions. Now, if we have a look at the study design and sample over here, there were around there were 200 high school students. These students were divided into four groups. Three of the groups received different levels of fear-based messages about dental hygiene, whereas the control group received a lecture on an unrelated topic. So pick on the information that I'm providing over here. We're talking about there being 200 high school students. These students, they were divided into four different groups. Out of these four groups, three of the groups, we refer to them as the experimental group, and the fourth group over here was a control group. So the three groups that received different levels of fear-based messages. And what were these different levels of fear-based messages? They were about dental hygiene, whereas the control group received a lecture on an unrelated topic. Now, all of these points, it's pretty important that we keep all of these points in mind. There were questionnaires that were used to measure emotional responses, beliefs, the attitudes, and the behavior before and after the lecture. So, having a look at what our book has to offer us, the study used three different levels of fear, appeal, and communication to 200 high school students. Now, remember, pick up on content that helps you evaluate your study better. The number 200 isn't bad, but at the same time, you're just focusing on high school students. Yes, the findings of the study might be applicable to teenagers, might be applicable to high school students, but the question that rises over here is, would this uh, would this would the findings of the study be applicable to people of the middle age or younger kids? Question mark. So the study used three different levels of fear, and when I talk about three different levels of fear, I'm referring to an independent measures design being used over here. So when we use the word independent measures design, we're talking about different participants having to go through different experimental conditions. The study used three different levels of fear, appeal, and communication to 200 high school students about dental hygiene. There were questionnaires used, and remember, questionnaires are an example of a self report measure. Questionnaires are an example of a self-report measure. Questionnaires were used to gather students' emotional responses to the communication, as well as to find out about the changes in dental hygiene beliefs, their attitudes, and practice. So, what is it that these questionnaires were looking at? These questionnaires, they were trying to gather the emotional responses that individuals had towards these different levels of fear-based messages. One, we're trying to look for, or we're trying to collect information on the emotional responses, taking this ahead to the communication, as well as to find out about the changes in dental hygiene. Were they effective enough to bring in a change in the beliefs that individuals held about dental hygiene, their attitudes, and their practices? The beliefs, their attitudes, and their practices. Now, taking this further, each group was presented with a recorded lecture and accompanying slides, all were approximately the same length. So we're talking about different groups being used over here. Each group was presented with a recorded lecture and accompanying slides, all were approximately the same length. Now, when we talk about the slides and the recorded lecture of being approximately the same length, we're talking about how the researchers ensured that the procedure was kept standardized. And of course, better standardization means the researchers had higher amount of control over the research, which would make it easier for anyone else if they want to replicate the study and verify, or replicate the study and check for the reliability in terms of the findings. So each group was presented with a recorded lecture and accompanying slides. All were approximately the same length, provided by the same speaker in a similar manner, and contained the same information about causes of tooth decay and the same recommendations for oral hygiene. Now, if you have a closer look at this, you'd see all of this helps us understand how the researchers were working towards improving the level of standardization that was there when level of standardization that was maintained when it came to uh, the different experimental groups over here. So again, like I said earlier, better standardization, better controls, better reliability. So all of these recorded lectures and accompanying slides, they were approximately the same length, number one, and they were provided by the same speaker in a same manner and contained the same information about causes of tooth decay and the same recommendations for oral hygiene. The three groups only differed in the amount of fear arousing material. So, like I had mentioned earlier, an independent measures design, the IVs over here would be manipulated while ensuring that everything else remains the same. Whatever possibly can be kept the same would be kept the same. So, having a look at the first group. The first group, we refer to this as the strong fear appeal group. So form one contained, or the first group contained, a strong fear appeal, focusing on the painful consequences of tooth decay, diseased gums, and other dangers resulting from poor dental hygiene. So we're talking about group one that we're referring to as the strong fear appeal group. Now, in this group, we'd study ahead that the participants were shown graphic images and there were direct warnings about severe tooth decay and gum disease. So ensuring that we're not missing out on any information that a book has. So form one or group one, we refer to this as a strong fear appeal group. This focused on the painful consequences of tooth decay, diseased gums, and other dangers resulting from poor dental hygiene. Personalized threat references were used where the audience was directly referred to. For example, statements that suggest this could happen to you. Now, this looks like an attack. This looks like the purpose over here is to ensure that the fear appeal is super strong. The slides used included 11 very graphic and realistic photos showing tooth decay and mouth infections. So yes, you could raise a concern related to the ethical guideline being followed. This could have caused distress to some participants. I hope you're noting down on the points that could help you evaluate your study better, like I say. Number two, the second category or the second group, we refer to this was better referred to as the moderate fear appeal. Now, form two contained moderate fear appeal, where the dangers were still described, but in a milder and a more factual manner. Using impersonal language, the slides used included 9 photos with milder examples than they were shown in Form 1. So the first group was referred to as the strong fear appeal. The next one, we're referring to this as a moderate fear appeal. Now, when we speak about this moderate fear appeal, we're talking about milder descriptions of dental problems with fewer disturbing images. Number three, we'd talk about the third group that we refer to as the minimal fear appeal group. Now, Form 3 presented a minimal appeal where there was hardly any mention of negative consequences. So, hardly any mention of negative consequences of poor dental health. The focus was on tooth decay, and the other two presentations was replaced with information about tooth growth and function. There were no realistic photos, and they only used X-rays and diagrams. Now, bearing in mind, I understand that the author for this book has provided a lot of information, but by the end of the day, know that this is an example study and not a key study. So, as long as you have understood the study well to be able to write a 6-mark question and understood it well to be able to give answers to questions that try to test your psychological knowledge on this particular study, that would be more than enough. Know that you would not be asked any direct question. I mean, they cannot ask you to give 3 characteristics of the third group, that was the minimal fear appeal group. I was just giving an example. So taking this ahead, in addition to these, there were in addition to these 3 groups described, there was also a control group. And when we talk about this control group, who were given a similar lecture on a completely different and an unrelated topic, the 4 groups were approximately equal in terms of age, sex, education level, and IQ. So again, this explains us how this independent measures design being used would be better referred to as a matched pair design. What is a matched pair design over here? Matched pair design is another example of an experimental design. This is just a fancier version of an independent measures design, because when we speak about match pair design, the idea is to match the characteristics of the participants. Remember, an independent measures design is when different participants are made to go through different experimental groups, and a and an updated version, or rather say an upgraded version of an independent measures design over here would be a match pair design. What is a match pair design over here? Match pair design is when you match participants in terms of different characteristics. Like, if you have a look at this particular study, we see that the participants that were allocated to these 4 different groups, the 3 groups being experimental groups and the fourth one being a control group. These participants were matched. The participants from these different groups, they were matched in terms of age, they were matched in terms of sex, they were matched in terms of educational level, as well as IQ. Now, the question that rises over here is, why would the researcher, or why would any researcher want to use a match pair design? Researchers usually, or psychologists, they usually use match pair design so that the participant variables that are there amongst participants, when they've been allocated to different experimental groups, they do not end up affecting the findings of the research. Now, taking this ahead, there were questionnaires that were given to participants. There was one questionnaire that was given 1 week. There was a questionnaire given 1 week before the lectures to assess health behavior. Number two, a questionnaire was given immediately after the lecture to measure emotional reactions. Number three, a questionnaire was given 1 week later to track any changes in the behavior. So, having a look at this, questionnaires were given out to all students 1 week before the lectures as part of a broader questionnaire about several aspects of health, with questions of interest relating to related to dental hygiene being dispersed amongst the other questions. Number two, immediately following the lectures, the students were given a questionnaire to measure the immediate effect of the communication. Then a follow-up questionnaire was given 1 week later to measure the carry-on effects of the communication. Like I mentioned earlier, there were 3 questionnaires, or the questionnaires that were given thrice. These participants, they had to fill out questionnaires thrice. We're talking about high school students here. And the first questionnaire was given 1 week before the lectures. The second one was given immediately after the lecture to check for the immediate effects of the communication. And the third questionnaire was given 1 week later, which it wouldn't be wrong if we refer to this as a follow-up questionnaire, because the researchers wanted to see, they wanted to track any sort of changes that were there in the behavior. Now, quickly, let's quickly take this ahead and talk about the results of this particular study. Results showed that emotional reactions immediately after the lectures varied significantly between those in the strong fear form and those in the minimal fear form. Understand this. If we speak in terms of emotional reactions over here, let me just highlight this for you. If we're speaking in terms of emotional reactions, results showed that emotional reactions immediately after the lectures varied significantly between those in the strong fear form and those in the minimal fear form. Now, what was the difference here? 74% of individuals from the strong appeal group or strong fear appeal group, they reported feeling worried. However, if you talk about the third extreme, that was the minimal fear group, there were only 48% of participants who, who reported to have gotten worried. So, for example, when asked whether the person felt worried a few times or many times about their own mouth condition during the lecture, the percentages who answered yes was 74% for strong group, 60% for moderate group, and 48% for minimal group. So, of course, if you're talking about a comparison between this and this, yes, this is a significant variation between the two groups. Taking this ahead, based on the responses to the questionnaire following the talk, students were given an overall score for level of concern. Now we're talking about scoring mechanism being used here, and when we talk about scoring mechanisms, of course we're talking about quantitative data being used. So the results showed that those in the strong group were significantly more concerned than those in the other two groups, and that those in the moderate groups were more concerned than those in the minimal groups. The mean scores out of 10 were 7.8 for the strong group, just highlight this, 7.8 for the strong group, 6.6 for the moderate group, and 5.9 for the minimal group. Now, if we are to figure out, or okay, so was this the actual purpose of the research? I mean, one thing that the researchers wanted to figure out was, would this get the researchers worried? Yes, if we have a look at the emotional responses or the emotional reactions, quite a lot of individuals, that is a huge chunk, 74% of the individuals from the strong fear appeal group, they did feel worried. If we talk about them being concerned, yes, out of a score out of 10, this the individuals from the strong fear appeal group, they scored 7.8 out of 10, which again very clearly shows us that the participants in the strong fear appeal group, they were concerned and they did get worried. Now the question that rises over here is, was this the primary purpose? No, the primary purpose was to see if all of this would bring in a change in the participants' behavior. And if this is not bringing in a change in the participants' behavior, what's the point then? Because the point is to promote health. The point is to make people not only concerned about their dental hygiene, but to promote health, or to promote dental hygiene in a manner that it is effective enough to bring in a change in individuals' behavior. Sorry. Now, taking this ahead, the research also investigated change in behavior as a result of the talks. 1 week before the talks, all students answered 5 questions about how they cleaned their teeth and were given the same question 2 weeks later after being informed on the correct procedure for teeth cleaning in the talks. Contrary to the idea of fear arousal encouraging health behaviors, the results showed that those in the minimal group showed significantly more improvement in teeth cleaning. Yes, you read this right. We're talking about how those in the minimal group showed a significant improvement in teeth cleaning. See, the purpose, like I said earlier, was not just to scare people. The purpose was to bring in a change in their behavior. The purpose was to help people, or to help these high school students uh, change. The purpose was to help these high school students change their attitude towards dental hygiene, to the point that they end up changing their behavior. Or yeah, so taking this ahead, so the results showed that those in the minimal group showed significantly more improvement in teeth cleaning, and those in the strong group showed the least improvement. Yes, so it actually worked the other way around. Furthermore, those in the minimal group were more likely to visit the dentist in the week following the talk than those in the moderate or strong group. So if it did affect, or if it was effective, it was effective for this group more, the minimal fear appeal group, because they were more likely to visit the dentist in the week following the talk than those in the moderate or strong group. There was a 18% of the minimal group, 14% of the moderate group, and 10% of the strong group. Yes, it's good knowing all of this. It's good understanding this, but be careful with what you decide on learning. I mean, I'm not asking you to not learn anything at all, but know that you need to learn, because you're not only studying this. One purpose is to educate you on this particular topic, but that, more than the educating part, what students care about at this point is how is it that they can learn content in a manner that they have to put in the least amount of efforts, and they end up scoring well. So know that this is an example study, and I've explained this to you numerous times earlier. So taking this ahead, it is important to state that this only shows us that students in the minimal group were more likely to say that they followed toothbrushing. So students in the minimal group were more likely to say that they followed the toothbrushing advice and went to the dentist. We cannot prove that they actually did carry out these behaviors, because of course all of this information that you're receiving is through a self-report measure. And when you talk about using a self-report measure, you're actually relying on the information that you're receiving from the participants. Finally, results showed that those in the minimal group were more resistant. Finally, results showed that those in the minimal group were more resistance to contrary propaganda following the talk. The talk spoke about the importance of the right toothbrush. Then, in the questionnaire, 1 week later, there was a paragraph explaining how a group of dentists claimed it didn't matter what sort of toothbrush you used. Students were then asked how important they felt it was to use the right sort of toothbrush. Results showed that students in all three experimental conditions showed some resistance to propaganda and were more likely to say that it did matter what toothbrush you used compared to the control group, but that those in the minimal group were significantly more likely to resist propaganda than the other two groups. So again, when it comes to resisting a contradictory propaganda following their talk, it was more effective for the students from the minimal fear appeal group. Now, taking this ahead, if we try concluding this, overall, the study showed that the minimal appeal was the most effective communication. Yes, it is very obvious, because it led to more resistance to contradictory propaganda and led to a high incidence of adherence to advice, at least as measured by the self reports. Of course, you can never be sure or certain. They were not only positive effects of the strong or moderate groups that would make them worth using instead of the minimal group. A strong fear arousal does not increase the likelihood of the audience taking information and guidance on board, and in fact seems to have the opposite effect. So I hope this has been helpful. And like I said, the first, the first section for this particular unit was strategies for promoting health. And the first section has two bullets. The first bullet over here was on fear arousal, the use of fear to improve health, including a study by Janice and Fishback in the year 1953. Taking this ahead, there's this another bullet that we see that says providing information. Or in other words, giving information so people know how to improve their health. Taking this forward, let's talk about providing information. Let's talk about providing information. To what extent do you think providing information would help participants improve their own health? If I try giving you an idea about the aim of the study, the study aimed, or Lewin et al. In the year 1992, aimed to investigate whether providing information and self-help strategies could help patients recover better after a high heart attack. So let me repeat. The researchers wanted to investigate whether providing information and self-help strategies, one, providing information, number two, providing them with self-help strategies, to what extent this would help patients recover better after a heart attack. Not only that, would help the patients improve their psychological health as well. So taking this ahead, another example study by Lewin et al. And the study aimed to investigate the effects of giving information to help people improve their own health. The study involved 190 participants who had been admitted to hospital after experiencing a confirmed myocardial infarction, that is also referred to as MI, which is a word that we use for a heart attack. So we're talking about participants who had been admitted to hospital after experiencing a heart attack. Taking this ahead, 3 days after the MI, and MI over here is myocardial infarction, which is a heart attack. So let's replace the word MI with heart attack over here. 3 days after the heart attack, patients were assigned to either the control or the experimental group. This was carried out in a stratified way to ensure each group had an equal proportion of age, social class, and initial levels of psychological distress. So let's try noting the important points from here. There were 190 heart attack patients who were part of the study. 3 days after the MI, patients were randomly assigned to either the experimental or the control group, while ensuring that there was an equal distribution of age, social class, and psychological distress levels. So again, you trying to match the participants. So again, we're talking about an independent measures design, a matched pair design. The person who held the list was blind to the purpose of the study, and the medical staff treating the patients were blind to the group the participants were in. So again, this over here, we're talking about how the person who was responsible for assigning groups was blind to the study's purpose, and the medical staff that was there were blind to patients' group allocation, and all of this was done to avoid biasness. And if you're taking measures to avoid biasness, you're trying to make your study, or you're trying to keep your study as objective as possible, which would of course add on to the credibility of the study's procedure and the study's findings. Now, moving on towards the procedure of this research, I hope everyone's understood this. We're talking about patients who had a heart attack. 3 days after they had a heart attack, independent. Note, this is an independent measures design. This is not a repeated measures design. So 3 days after the patients had a heart attack, they were randomly assigned to either the control group or the experimental group. Now, both of these groups, they had participants with an equal proportion of age, social class, and their initial levels of psychological distress. The researchers ensured that the person was assigning the participants to these two groups, either the experimental group or the control group, they were kept blind or they were not aware of the study's purpose. And at the same time, the medical staff that was involved over here also was not aware of the patient's group allocation. Now, taking this further, moving on towards the procedure of the research. So we're talking about the procedure over here. On discharge from hospital, those in the experimental group were given a copy of the manual. Now, the people or the participants in the experimental group, they were given a copy of the manual, which consisted of 6 weekly sections, including education, home-based exercise program, and a recorded relaxation and stress management program. So what we're talking about is the participants who were in the experimental group, the participants who were there in the experimental group, these participants, when they were being discharged from the hospital, they received a copy of a manual, which consisted of 6 weekly sections that included number one, education, number two, home-based exercise program, and a recorded relaxation and stress management program. So these were a part of it. I'm not saying the manual just had this. So the manual also contains specific self-help treatment for intrusive and distressing thoughts, anxiety, depression, and other psychological problems common with patients following an MI. So, of course, when you're talking about a patient who has just had a heart attack, there is, I mean, we can't expect them to be happy about it. There's a possibility, or there are high chances that these participants would feel anxious, they'd feel depressed, or they could have other psychological problems as well. So to be able to cater to that, this manual that we're talking about, the manual also contained specific self-help treatments for intrusive and distressing. Now remember, when we're talking about the aim of the study, when I was trying to explain the aim of the study, I'd use the word self-help strategies. These are the self-help strategies that we're talking about. So the manual also contains specific self-help treatments for intrusive and distressing thoughts, anxiety, depression, and other psychological problems that were common with the patients following an MI. The patient and the partner, where possible, was introduced to the manual by the facilitator. The patient and their partner, of course, I mean, we don't expect the patient to be left alone by the family. So the patient and the partner, where possible, was introduced to the manual by the facilitator, who explained the components and how to use them. Patients in the control group were also given time with the facilitator and were given a range of leaflets from different sources that gave them information about recovery from an MI. So understand the difference. What is it that is making the experimental group different from the control group? The experimental group received a manual. The experimental group received a manual, whereas the control group did not. And instead of the manual, the control group received a range of different leaflets from different sources that gave them information about recovery from an MI. After 1, 3, and 6 weeks, all patients were contacted by the facilitator. So after 1, 3, and 6 weeks, all patients had brief check-ins via a phone or clinic visits. So after 1, 3, and 6 weeks, all patients were contacted by the facilitator, usually by a phone call or during a clinic visit. Those in the experimental group had a check on their progress with the program and were encouraged to stick to the exercises. Now, additionally, the ones who were there in the experimental group, they had a check on their progress with the program. What program? The manual program. And they were encouraged to stick to their exercises. Those in the control group were given general encouragement and support and had questions answered. So anxiety, depression, and general psychological health were assessed by questionnaires over here as well. After 6 weeks, 6 months, and 1 year. So remember, the idea over here was to, if you go back to the aim of the study, the researchers additionally also aimed at improving the psychological well-being of the participants. So to cater to that, anxiety, depression, and general health were assessed by questionnaires after 6 weeks, 6 months, and 1 year. And the patient's doctor surgeries were asked to report the number of contacts they had after 6 months and after 1 year. So, of course, if you're not doing well, you would contact your doctor. So the doctor visits and hospital readmissions were also recorded at 6 months and 1 year. The researchers wanted to see if this what do you call it, a manual. The researchers wanted to see if this manual was actually helpful or it was not helpful. You see how the third part that I mentioned, that we see over here, that says the there were home-based exercise programs and a recorded relaxation and stress management program. So let's see how this actually helped or it did not help. So, anxiety, depression, and general psychological health were assessed by questionnaires after 6 weeks, 6 months, and 1 year. And the patient's doctor surgeries were asked to report the number of contacts they had after 6 months and after 1 year. If you have a look at the results of this study, results showed that anxiety levels had dropped significantly. The results showed that anxiety levels had dropped significantly more for participants in the experimental group compared to the control group at both the 6 week and 1 year follow up. Depression scores only differed significantly at 6 weeks. Now, this is a bit too much of detail. This is an example study, but it is what it is. The number of patients showing poor general psychological health, referred to as caseness, was significantly lower for those in the experimental group than those in the control group at 6 weeks, 6 months, and 1 year. Results also showed that for the patients who were identified as particularly distressed at the time of MI, anxiety and depression levels were significantly higher for those in the control group at each follow-up. Visits to the doctor and readmission to the hospital were higher for those in the control group than those in the experimental group for both the first 6 weeks for the first 6 months and the following 6 months. Lewin et al. Concluded that providing patients with information and with a self-help program can significantly improve their recovery after an MI and can significantly improve their psychological health during recovery. So this was the study in a nutshell, in a single line. The patients who received the manual, they did better. They had fewer hospital visits. Not only that, they also reported better psychological, or they felt psychologically better. Now I'd want you to spare a minute reading through this, and then we continue. Now, this is the flashcard that has been provided to you, and if you see, going through this would help you not only revise your study better, but I think this has, if you know and if you read your study thoroughly from the book, I think this can help you write an amazing 6 mark answer where you could hit a 6 on 6. So this is the first bullet that was the study was that was conducted by Janice and Fishback, and the second bullet study that was based on providing information to improve health. So this could help you write better 6-mark descriptive question answers, and save you time and guide you as to what the important things are that you need to know for a particular example study. So this brings the first section to this unit to an end here.